So I'll introduce Dr. Levin. She's a professor of medicine at the University of British Columbia, and she's the director of the Kidney Function Clinic at St. Paul's Hospital, as well as the executive director of the BC Provincial Renal Agency. And it's an organization which manages and coordinates the care of patients with kidney disease across this province, and it's developed and maintained a provincial registry of people living with renal disease. Her research and clinical activities focus on chronic kidney disease and the comorbidities that are associated with chronic kidney disease, as well as health outcomes research. She's always active in mentoring young researchers and future physicians who are going to be taking care of people living with kidney disease and kidney-related research. She also holds numerous grants for clinical studies in this area. She's received peer-reviewed funding from CIHR, the Kidney Foundation of Canada, Michael Smith Foundation for Health Research, and the Ministry of Health Services of BC. She's also the principal investigator of a number of studies funded by industry, but designed and developed by the investigator. She's been awarded the Providence Healthcare Senior Scientist Award for research in 2008. And in 2009, she received the prestigious John B. Dossiter Mission Award from the Kidney Foundation of Canada for her contributions to kidney research. So we're very fortunate to have Dr. Levin be here at St. Paul's Hospital, and also it's a great privilege to have her speak to us today. So please, I'd like you to give a round of applause to her.
So again, my thanks to Anita and to the organizers for asking me to do this, and hopefully in the next 25 or 30 minutes I'm going to be able to give you a bit of an overview of amazing kidneys. I think we always talk about disease, but we don't always talk about health, so I thought it would be nice to know what your kidneys do when they're healthy and what happens when they don't work so well. By way of introduction, the notion behind, I think, this forum and many others is the more information you have about lifestyle, diet, how to monitor your kidneys and medications that might be damaging or helpful to your kidneys, then the healthier they can stay. And so by way of this forum, I'm hoping both to stimulate questions and answers as well as to give you information that you can use to keep your kidneys healthy. So first of all, I thought we'd start with where they are, because not everybody knows that. So they're two little kidney-shaped fist-sized things that sit behind your ribs in the back, not in the front. And most people have two of them. You can live really fine with just one, because God gave you two kidneys so you can give one away if they're healthy to someone who needs them. That's my plug for transplantation. They're fed by blood supply, like all organs in the body. Arteries and veins take the blood away. And they actually are pretty amazing little beans. What they do is they control blood pressure, excrete waste products, and balance the inside of your blood so that it's perfect. A little bit like when you go to bake a cake, you've got to have all the right things in it so everything works perfectly. So it is with the blood. There has to be the right amount of salt and water and potassium and bicarbonate so that your cells work properly, and that's what the kidneys do. They also secrete and activate important hormones. They do a lot of things. And just to expand on that a bit, they control your blood pressure by controlling salt and water excretion and hormones called angiotensin and aldosterone. And you might hear those words, that's why I put them there. They excrete waste products, and that's important because when they don't work, those products go up and you can measure them in the blood. As I said, they balance the internal milieu of the blood, which is the acid, the potassium, calcium, phosphate, and other things. And all of those are the things that help your cells, your heart, your blood vessels, everything to work well. And the important hormones that they either secrete or activate are things like vitamin D. You've heard a lot about vitamin D in the press these days, but the vitamin D by itself, until it's activated, doesn't work on all of your vital functions. And there are vitamin D receptors in your heart, your blood vessels, your brain. And the kidney actually activates the vitamin D so it can actually bind to those receptors and do all the great things like regulate your heart function, immune system, and other things. It also secretes a hormone called erythropoietin, which helps you to keep your blood levels up and also is really good to protect against tissue damage. They're pretty amazing in terms of all the things that they actually do. They filter 120 liters of blood per day, and they receive 20% of the cardiac output. So every time your heart pumps, 20% of that one beat goes to your kidneys. And they're so clever that despite getting all those liters of blood filtered through these various filter mechanisms here, which are seen here in the pyramids, you only put out 1 to 2 liters a day, so it can reabsorb stuff, get all the milieu right, and then only let you excrete 1 to 2 liters. And as I said, it balances salt and water excretion over a very wide range of intakes. So on the days where you don't drink a lot, but you need to get rid of waste, they can do that. And when you drink too much, it can get rid of that without getting rid of too much waste product, because you don't need to. And I think that that's a pretty interesting ability to balance, and probably what we don't necessarily appreciate. So there's some pretty simple measures of kidney health. One is blood pressure. One are blood tests that measure if the kidney's filtering properly, and I'll talk a little bit more about that in a few minutes. But creatinine, which is a blood test that's measured, is used in an equation that estimates your kidney function. And I'll give you a little bit more detail about that. And there are urine tests where, I don't know how many of you have been to the doctor lately, but and they ask you for a urine sample. We can look at it under the microscope and see if there's red cells or white cells. And we can also dip it with a little stick and see whether or not there's protein. And just for ease, you're not supposed to have protein or albumin or cells in your kidney, in your urine. So that's what kidneys do when they're healthy. How do you know what is really chronic kidney disease? And you hear people talk about chronic kidney disease or CKD. So it's worthwhile saying what that is. Kidney disease actually describes a variety of diseases. It's not one thing that affects the kidneys. And most kidney diseases attack those filtering units of the kidney, which I showed you in those pyramids, and make sure that they don't eliminate waste and excess fluids is one of the key things. It's defined as a decrease in level of kidney function, but you have to have it for 3 months or more for it to be really called chronic kidney disease. So there's something called acute kidney disease, which in medicine what we mean by acute is something that just happened and might be reversible but might not. And it might be different, and so you'd have to ask your doctor, do I have kidney disease? Do I know that it's a long time or a short time? And sometimes short time means you can reverse it or do something about it or understand it better. Conventionally, as of 2002, we actually began to divide chronic kidney disease into 5 stages to help both doctors as well as people living with kidney disease to actually understand in a much more clear way how severe the damage is in relation to level of kidney function. So GFR, which is stands for glomerular filtration rate, so the filtering of each of the little tiny filtering units in the kidney, is just a mathematical estimation of your kidney function. It's based on things like age, gender, and creatinine, which is the kidney blood test, and it describes a percentage of kidney function. And this is just a graphic to show you how we've divided up kidney function, right? And most of us actually have kidney function that's above 60%, and we only have kidney disease if you also have something else wrong with your kidneys. So you might get a number back from the lab or your doctor that says 72, where you might think, oh my goodness, I have stage 2 kidney disease. You don't have stage 2 kidney disease unless you have something wrong with your kidneys in addition to the number. You have to have protein in your urine, a biopsy that's abnormal, or something else, not just because normal people can have slightly reduced function, and that's just part of a normal distribution. Just like people have blue eyes and brown eyes and short hair and long hair, you can have different amounts above 60, which are normal. And then when you have stage 3, you have below 60% of kidney function. So that's how this is graphically represented. And each of those tends to be associated with an increase in symptoms, but not everybody has symptoms, and we can talk about that hopefully in the question period. So this is just to give us a perspective, and there's different ways that we've calculated how many people in British Columbia or Canada have kidney disease. We estimate in Canada that about 1.2 to 2 million people actually have kidney disease as defined by lower kidney function. You can add up the numbers here, and this is a conservative estimate. Of all the people with lower kidney function, only 14,000 people in Canada have dialysis or have a transplant or are on dialysis. So the proportion of people that get to what I call end-stage kidney disease, which isn't a very nice word, but it's old, so we always use it, or kidney failure, is not nearly as great as the people that have reduced kidney function. And that's both a good thing and an opportunity to intervene and understand and keep your kidneys healthy. And it's something that we can keep our eye on a little bit more, and hopefully we'll talk a little bit about the things that you can do and the research that we're doing to try and keep that proportion as small as that. So kidney disease can strike anyone at any age. It's more common the older you get. And as I said, an estimated 1.2 to 2 million people have kidney disease or are at risk. And each day in Canada, an average of about 14 Canadians learn that their kidneys have failed. Right? It's only one per province, really, if you think about it. But it's every day, so that's actually a lot of people. And in 2008, we had 36,000 people on renal replacement therapy. And by various estimates, especially as people live longer with diabetes and heart disease and other things, which I'll come to in a moment, then it's thought that more and more people will have mild or moderate reductions in their kidney function. That doesn't mean they'll need dialysis, and we'll come to that shortly. So what are the signs of kidney disease? And you can read them in a list, which I have at the end, but sometimes seeing it gives you a better perspective. So these are... So high blood pressure is one, but lots of people with high blood pressure don't have kidney disease. But it may be that if you have high blood pressure and then it becomes harder to control, your doctor might worry that your kidneys aren't working as well as they should. You can get swelling. Remember I told you about the fluid and salt retention, the excretion the kidney does? Well, when they don't work so well, sometimes you get puffy around your eyes and your ankles get swollen. Not the kind of swelling that you get on an airplane when you've sat for too long, or you've had a big salt meal or something like that, but actually more like that is in this picture. Some people lose their appetite and really don't feel like eating or drinking anymore, and often people notice either a decrease or an increase in their bathroom habits, especially urination. So some people will pee a lot more and some will pee a lot less. So how much isn't necessarily, having a lot doesn't necessarily mean you have good urine. Some people complain of a lot of itchiness, mostly at night, and very pathological, and they'll notice a change. And then there's a nonspecific thing, which is just feeling really tired, and that all of us feel most of the time, so it's not very specific. And usually what we're looking for is the constellation of things together, or a quantitative and qualitative change in those symptoms, and in association, obviously, with changes in some of the blood work. So just to go through high blood pressure, fluid retention, changes in urine color or consistency. So some people notice that their urine is frothy, red or brown, even if it's intermittent, and that might signify a change. And then I spoke about the fatigue, itching, muscle cramping, not the kind like, oh, I have a cramp once in a while. We all do that. But severe muscle cramping that makes you get out of bed and have to walk around the bed a few times before it will go away. Quite profound. Again, mostly at night, not during the day. And some people complain of a metallic taste in their mouth, but that's often as the kidneys are much closer to failing. So these aren't early signs. I think the hardest thing about kidney disease, it doesn't hurt most of the time. So people are fine, and then they have these little things that niggle, and then over time they'll develop a worsening kidney function, and towards the end of their kidney's life, they've got this funny taste and everything else going wrong. So who should we test for kidney disease? If you or anyone you know has diabetes, high blood pressure, heart disease, either heart failure, which also isn't a good term, or have ever had stents put into your coronary arteries, or had a stroke, or at risk for a stroke, or have vascular disease in your legs, or if you have a family history of people on dialysis or transplant, then you should be tested for kidney disease. There are specific ethnic groups that are at very high risk of kidney disease, not just because they have diabetes, which is also part of what happens in some groups, but because there are a number of other reasons as well. So First Nations people in Canada, Oriental and South Asians, Pacific Islanders, and that should actually say Canadian, African Canadians, or it's actually African Americans as well, but there are African Canadians, so it's not in the literature quite as well written. So. And so these groups are often at high risk, and they often also fall into one of these categories because they'll often have a family history of kidney disease, which actually makes it easier to test them. So what are the reasons for kidney disease or changes in your kidney function? So I've listed them here in terms of acute, like I told you about before, and chronic. So the acute changes are things like severe infections can actually damage your kidney. And in childhood, that's often a cause for an acute change in kidney function in a child, which leaves some scarring and often is okay until they get to be older. Drugs, arthritis drugs, and some antibiotics can also cause kidney disease. Systemic diseases, which are more rare, things like lupus or vasculitis, which you may or may not have heard of, but these are other things that acutely change your kidney function. And things that block the kidneys, either kidney stones or prostate or cervical cancer, anything that gets in the way of that picture I showed you at the beginning of how things get out of your body is going to be a cause. And the chronic changes I mentioned before, diabetes causes a lot of problems with blood vessels, as well as the kidneys are a million little blood vessels, so they actually get scarred the same way. High blood pressure causes, think of high blood pressure as being like putting a fire hydrant hose onto a spider web. Like that, there's such a fine, lacy network in the kidney, and yet that's what high blood pressure does. It really damages them, and then there's repair. There are a series of inherited kidney diseases, and that's part of the family history part. And then heart failure, as I mentioned before. I think importantly, things that cause acute changes can ultimately lead to chronic changes. And so we know from increasing research that multiple times where you have something happen to you where your kidneys don't work so well and then they recover puts you at risk over time for chronic changes. So again, the more you know about kidney disease and the more you know about things that can hurt your kidneys, then the more you can sort of be on the alert for it. So what happens if you have kidney disease? What will happen is that someone will do a blood test and determine that your kidney function and the urine is not so normal. So we'd have to determine the cause and make sure that any of those acute or reversible causes, is treated. We then regularly monitor your blood tests, urine tests, and blood pressure. You'd get some dietary advice because we know that diet is a very important component of kidney health, like it is of heart health. We'd review and adjust any of your medications that might actually interfere or be making things worse and add things that we know would make things better. And sometimes, but not always, we'd be referring you to kidney doctors or a kidney team. It's not always necessary, and many people in consultation with the general practitioner and the kidney doctor might say, there's no huge advantage, there's nothing to worry about, here's how you monitor it. And in fact, when you need to come to be seen by a kidney team, you can and get quick access, but not everybody needs it because it's so common. It's like not everybody needs to see an endocrinologist just because they have diabetes. General practitioners are becoming better and better and better at managing this. So how do you prevent more damage? The same ways that you promote heart health is exercise and healthy eating. Keeping your blood pressure, I don't know, there's a lot of movement now in terms of people knowing all of their numbers, so you should know what your blood pressure is, and if you don't, I would advise you that it's probably good practice to ask your doctor when you go to the doctor what your blood pressure is, and it should be less than 130 on 80, whether you have kidney disease or not, and 120 on 80 if you don't have anything wrong with you. Blood sugar control. Diet, because we know that reducing protein and phosphate actually helps with your kidney health as well as your heart and blood vessel health. We sometimes try and make the protein in your urine lower, so we often will do drugs or manipulations to do that. We give you a list of drugs to avoid or change, and we'd have regular follow-up and monitoring with blood tests. So the big medicines to avoid are anti-inflammatory pills, so things like Celebrex and naproxen and things like that. We think that if you don't really need to take those medicines, you probably shouldn't. Probably none of us should, but if you have any kidney problem, you really shouldn't. Certain antibiotics, if you have reduced kidney function, can make your kidney function worse. So you shouldn't, and your doctor will know that, and so will the pharmacist. And right now, certainly in BC, we're very fortunate because the pharmacists have a lot of knowledge, and they're actually paid essentially to make sure that if you tell them something about your health, they can inform you about whether or not you should or shouldn't take things. I think that's very important. Intravenous dye. So sometimes people will order tests for you and you need to get intravenous dye, but actually that's a bad thing if you have a kidney problem. So I write that there. And often, again, the radiologists are also experts and consultants, and they can often find another test for someone to do that doesn't require dye that won't hurt your kidneys. Smoking is bad for everything. So sometimes I get my patients to quit smoking, forget about their lungs, I don't care. But it actually is they seem to be way more afraid of being on dialysis than they do of actually getting lung cancer, or bad lung disease. But smoking is certainly an accelerator of kidney disease. And so it's important to pay attention to stopping smoking. The whole reason that we do all of this is to reduce symptoms and prevent complications of losing all those functions that I told you about at the beginning. The hormones, the salt and water, the internal milieu, all those things don't work when your kidneys don't work. So there's a whole bunch of things that go wrong. So if we can prevent the complications that come from that, and sometimes it's by adding in medicines that replace those hormone functions, and sometimes it's to trick the body into thinking that things are balanced from the outside instead of from the inside. But we can reduce symptoms and prevent worsening heart and vascular disease. It's important to make timely treatment decisions and to delay or avoid dialysis, and that's what we're trying to do, or prepare you. And I think that importantly, I'm here to tell you that, yes, it changes your life, but avoiding dialysis, if you have to make those decisions, and not preparing properly actually makes it worse than better. So there's a lot of discussion now about self-management, and many of you in this room may know about chronic disease self-management programs. There are some that are through the University of Victoria and through Vancouver Coastal. But basically it's to manage your symptoms, change your lifestyle, learn how to talk to your healthcare team, acknowledge and manage the fears and frustrations of having a chronic condition that doesn't have an absolute outcome. So I can't tell everybody what will happen to them. And as Anita was alluding, Dr. Palapu was alluding to, some of my research is so that we can help to predict better who will progress and not progress. Because I think the hardest thing right now is to look at 6 people with kidney function of 30%, and 4 of them won't progress, but I can't tell you which 4. And so everybody has to go through the same blood pressure control, all those, and all the diet and stuff, even if I don't know that absolutely they're going to have the same benefit from it. Everybody will benefit from modification in their lifestyle, but not everybody's kidneys will necessarily benefit to the same degree. So that's one of the things that we try to do. We have to learn how to problem solve. The healthcare system, for those of you that have ever been in it, is a complex place. When you have a chronic condition, it's even more complicated. And so how you actually navigate. And one of the other goals is to get more out of life. So I wanted just to spend a little bit at the end now to tell you about the outcomes of people with kidney disease and the fact that they're very variable. Some people have no progression. They remain at risk of problems with dye and drugs and infections and things like that, but they actually have stable, reduced kidney function, and they will for a very long time. There are people that have slow progression without any kidney failure. So they reduce their kidney function about 1 to 3% that I showed you before, or mils per minute per year. And they have pretty acceptable kidney function without symptoms or other problems, despite the fact that it's slowly getting worse over time. And that doesn't mean you shouldn't worry and do lots of stuff, but it means that you don't have to worry as much about those scary words, dialysis and transplant, which we'll get to. And then there are a group of people who progress to end-stage kidney disease, whether they're going quickly or slowly, where the kidneys actually fail and we need to replace their function with dialysis or transplantation. So from a large group of referred patients to nephrologists, I can tell you that about 28% of 4,000 people in British Columbia have no progression over time. Slow progression without kidney failure occurs in 46%. And this is the remaining quarter actually have this progression to end stage. So that's like a 3/4, 1/4 ratio. So it's actually much better than perhaps you might have thought. So having the diagnosis of kidney disease doesn't mean, oh my goodness, I'm going to end up with a transplant or on dialysis. But if you need dialysis or transplant, what those 2 things do is they replace kidney function along with medications. And dialysis is meant to promote independence. You can do it at home. You see lots of people coming to hospitals and doing dialysis in hospitals, but you don't have to. You can do all of them at home. Peritoneal means you do it through the tummy, and they put a little tube in your tummy, and hemodialysis is something that you do with a machine. Again, you can do that at home, either with a special catheter in your neck or with something in your arm. Done well and planned in advance, all of these should truly be non-traumatic and should be done with a full team and started as outpatients. And that's our goal. Now, our biggest frustration as a kidney team is when people don't want to make decisions because they want to think that everything's going to be okay, and then it does become a drama, and it becomes really scary for everybody when you have to start emergently. Transplantation, you've heard a lot about in the news. There's a CBC series being aired this week, starting again. There's living donors and deceased donors. So living donors is not necessarily a family member, but could be a family member or a friend that matches. I don't know how many of you remember the few articles in the Globe in the recent past where we did something called paired exchanges. And those are actually quite fantastic, where somebody wants to give a kidney to someone else, but to one of their friends or loved ones. They don't match. Same thing occurs in another pair, but this one matches this one and this one matches this one. So they give to each other's people. And you can do that in what we call a domino. So we've actually done it in 4 pairs of people, so that all the operations go on at the same time in all the operating rooms. And it's quite an amazing testimony to the human spirit, actually, what people will do for each other. So there's lots of different ways to do transplantation. What I have learned in talking to people is most people with kidney disease aren't very good at asking people to donate kidneys. So for those of you that are very healthy and well, if you know anybody, sometimes offering kidneys, even if you haven't been asked, is something that is hugely helpful. And deceased donors is people who die, usually in accident or unexpectedly, who wish their organs to be given away. And there's certainly an excellent system in this province that we're trying to actually even make more robust to actually improve for that, because believe it or not, in British Columbia we have the lowest deceased donor transplantation rate in the country. And it's not exactly clear to me why that is, but it's pretty sad. So for all the lovely altruistic people we have in this province, it's not clear to me why people don't want their organs given, so we need to work on that. All of those things, including conservative care, which is there are many people, especially older people, who have lots of other things wrong with them, who really don't want themselves or their families to invest the time in dialysis or transplantation. And we respect that decision. And that's what we call conservative care. You get all the care you would have got, but you just don't get all the discussions about dialysis and transplant. But all of these, dialysis, transplant, conservative care, and preserving your kidney function, requires planning and teamwork, not just by medical teams that are specialist teams, but by your general practitioners and other specialists, the kidney team, and your family and your other support system. And I think we often underestimate the amount of energy that everybody has to expend, irrespective. This is a diagram I used to remind the general practitioners that this is truly a coordinated effort between the nephrology team, and we try and manage patients over the spectrum of kidney disease together, so that they still get a holistic approach to all of their care. So the bottom line is that kidney disease is usually not anyone's fault. It's sometimes just bad luck, and mostly it's just bad luck. There are lots of people with diabetes who never get kidney disease, and there's people that take really good care of their diabetes and get awful kidney disease, and people who don't manage their diabetes well and don't get kidney disease. So usually it's not your fault, but if you get it, it certainly does change your life. The importance here is to work effectively to reduce the negative impact on you and your family, because I think that with more knowledge and more understanding of the possibilities, we can help to manage all of that with you. And we do have effective strategies to improve outcomes, and I think for that reason, we're trying to educate as many people at very early stages, at later stages, have more peer groups, make it not so scary for people, but acknowledge that it sounds almost as scary as cancer to most people. And in fact, in a recent study that I just saw, when people with kidney disease were told they had cancer, they perceived that as much worse than having kidney disease. But in fact, it's almost identical in terms of what it does to your life. So it's a quite interesting perception that people still have. So I wanted to conclude by thanking all the people who participate in making the lives of people who live with kidney disease better. And there are lots of them. I listed them there for you. So what I tried to do is give you a little bit of an overview of the why, the who, the when, and the how of kidney disease. And I think that what we can do now is probably ask you to ask me questions about what you have about kidney disease as it pertains to yourselves or your family, or kidney health as it pertains to you and your family, and hopefully clear up any myths or clarify things. So I thank you for your attention, and we could ask some questions now.